We are ready.
Hello, my name is Jose Farina. I'm an obstetrician and gynecologist. Been in practice in San Antonio, Texas for 32 years. I'm board certified, and I've been at this trade for, like I said, 32 years. As I understand, the interest in this meeting is for a discussion on conception and preconceptional counseling. What do you say to a patient or a couple that come into your office wanting to know what to do before they conceive? And actually, it's not that difficult for 80% of the population or 80% of couples. If you leave 80% of 100% of couples alone for a year, 80% of them will conceive within that year with no problem whatsoever. So what you do, or what my routine is on preconceptional counseling, is to get a brief medical history, specifically of the mother. The father doesn't really, is not so significant for people that are not infertile. And infertility, we got to remember, is defined as not being able to conceive for 1 year after purposely trying to conceive. So if everything is normal, what I usually do is get a medical history on the mother, and you got the significant or the more significant problems that the mother might have is she a diabetic? Is she hypertensive? Is she obese? Has she had problems in prior attempts at conception? Has she had problems with a pregnancy? She's been pregnant before. This type of thing. There were some questions raised, and I'm going to kind of answer one of them since we're talking about this, and that is about the effects of long-term contraception on pregnancy. And the reality is that most contraceptives do not affect fertility. In other words, if you're on the birth control pill for 9-10 years and then you stop it, your fertility should be, all things being equal, normal. In other words, if you were destined to be infertile before the pill is not going to make you more infertile. And the traditional way of dealing with the contraceptive pill in somebody that wants to conceive is to stop the pill, ask the patient to use a different method like condoms or abstinence or whatever for 1 month until she has a normal period. And the reason to do that is not to allow the pharmaceuticals or the chemicals to get out of the bloodstream. The reason to have them menstruate on their own once is because obstetricians are lazy by trade and we want to date their pregnancy. So if you have them have a regular period before they attempt to conceive and then they conceive in the following cycle, we'll know how far along she is. And that is the only reason. The birth control pill, the Mirena IUD, the Paragard IUD, the dermal patch, the NuvaRing, none of those methods are going to affect fertility in the least. The things that affect fertility is first, if the patient has issues with ovulation, and in our society nowadays, the most common reason for anovulation is obesity. We have a pandemic of obesity in this country. So with increased body weight, fertility decreases because of the lack of ovulation. There's a point, and every woman has a different level of this, where body fat interferes with hormonal function and interferes with ovulation. So that it would be a much more common cause of infertility than contraceptives are. The other thing that we have a problem in this country with is venereal disease, chlamydia being the most significant one. It's said that the population under 30, there's a 70% incidence of chlamydia. And we know that chlamydia causes tubal occlusion and therefore infertility. So, in your process of counseling these patients, you should ask about a history of venereal disease too. The venereal disease is not going to interfere with the pregnancy, but it will interfere with the fertility. And again, I think I answered the second question. Is there a time frame between stopping contraception and conceiving? And there really isn't. The reason to do it that way, or to make them at least menstruate once, is to, like I said, to date the pregnancy. But if the patient stops whatever method today and the following day she gets pregnant, it's not going to cause pregnancy loss, or it's not going to cause infertility. The other thing you should do in your preconceptual counseling is encourage the patient to start taking folic acid 7 to 8 weeks prior to conceiving. And the magic number for somebody that has not miscarried in the past is 700 to 800 micrograms daily of folic acid. The easiest way of doing that is to tell them to start taking prenatal vitamins. That I know of in this country, just about every prenatal vitamin, even the ones over the counter, are at least 700 to 800 micrograms of folic acid. The British are the ones that came up with this because their incidence of venereal tube defects is 3 times greater than it is in the United States. And they came up with the idea that folic acid prevents neural tube defects. And then the further research showed that folic acid tends to prevent pregnancy loss. So it's a good idea if the woman is trying or planning on conceiving to tell her, hey, 7 or 8 weeks, a couple of months prior to conceiving, it might be to your advantage to go on folic acid. And certainly somebody that comes into the office and is pregnant early in the pregnancy, you should encourage them to take folic acid. Now, the other question that was raised is the question about the effects of fertility, age on fertility. In other words, what is the effect of being over 35 on conception? Well, the number 35, there's no magic about it. We know that the woman is born with a number of eggs or follicles that she is going to have for the rest of her life. And throughout her whole life, she just loses those follicles, whether it's by atresia. In other words, the follicles are not used or released, and they kind of resolve or reabsorb, or because she uses them and conceives. So in reality, an 18-year-old has less fertility than a 16-year-old, and a 20-year-old has less fertility than an 18-year-old. The number 35 is because in the past, once the woman reached the age of 35, it was thought that the risk of undergoing an amniocentesis for genetic testing was justified because of the risk of birth defects was greater at that point. But a 35-year-old has a better chance of conceiving than a 36-year-old. Now, once you get into the 40s, 41, 42, 43, your chances of conceiving on your own decrease significantly. I think that if memory serves me correct, a 41-year-old has a less than 1% chance of conceiving on their own. That doesn't mean they cannot conceive through, manipulation of the ovaries and stimulation of the ovaries to generate a follicle so they can conceive. That's my friends, the infertility folks, are the ones that do that kind of thing. And it's fairly commonly done nowadays. As women have entered the workforce and have professions and so on, they become more willing to wait to conceive. So once they decide to conceive, fertility has become a little more difficult because of age, maternal age. Now, there's a decrease in fertility on the male side. It's not all women, but the decrease in fertility on the male side is much less with age. There's been some talk about older men having a higher chance of certain uh, abnormalities in the fetus and in the children, but it's relatively nowhere near as significant as it is in women once they get past 35, 36, 37. Now, how do you determine fertility? How do you determine that a woman is ovulating? Because fertility, you've got to remember that fertility not only requires ovulation, it also requires fallopian tubes that are not blocked or damaged or they're patent, that they have the cilial mechanism that is within the fallopian tubes is functional, because chlamydia damages that cilia, that the little hairs that the women have in the fallopian tubes that make that egg move down the tube so they can go back to the uterus and implant. So how do you determine that? If a woman is menstruating on a regular basis, 26 to 30, 32 days cycle, and the definition of a menstrual cycle is the first day that they menstruate, the first day that they bleed, and it doesn't matter whether it's one spot or a gush, as long as the first day of the cycle is the first day of menstruation, and you count from there. And if the woman is having 28-day cycles, which is traditionally the normal cycle on a fairly regular basis, then you have a 90% chance that this woman is ovulating on a regular basis. And if she asks you, well, my cycles are 28 days, when am I ovulating? Well, you subtract 14 from that 28-day cycle, and that's probably about the time that she's ovulating, about the middle of the cycle, about day 14, day 13, day 16. Now, the traditional way of doing this was to tell the woman, do this calculation, and based on this calculation, this is your fertile period. And the recommendation was, intercourse every 48 hours, with the thinking being that the man needs 48 hours to generate enough sperm to fertilize the egg. That's kind of controversial nowadays. People think that maybe once a day it's fine, and the decrease in the number of sperms is not that significant. But traditionally was wait 48 hours every other day intercourse, and you should be able to conceive. Again, infertility is defined as 1 year without conception, with no with a purposeful attempts at conceiving. So I think that you have to temper this based on the age of the mother, but for a woman that is in her 20s, mid-20s, you should probably wait that 1 year. I see a lot of women that are in the mid-30s, late 30s, and they're concerned, and they have not been able to conceive for 3-4 months. And I think it's a call whether you start a workup for infertility or not at that point, thinking that she is getting to the tail end of her fertile period, and that might justify the workup. Now, infertility workups, you got to remember that you got two patients. You don't have one patient, that being the woman. So even though there's a lot of resistance about doing this, one of the first things you should do with an infertility workup is to test the father. A semen analysis, sperm count is not expensive in the greater scheme of infertility workups, and it's not painful. And once you rule out azospermia or decreased sperm or abnormal sperm or sperm that are not moving on the male, then you have a clear shot at trying to work up the woman. The other thing you remember, and I see this quite a bit in my practice, is that they'll come in wanting to know if they can conceive, but they're not interested in having a baby at this point. Well, infertility workup and infertility treatment is the purpose of it is to get the couple pregnant, to have the woman conceive. And if they're not ready to conceive at that point for whatever reason, then I don't think that you should do a workup. Unless there is extenuating circumstance, like if the mother tells you, I had a real bad appendicitis, ruptured appendix, treatment with antibiotics, I had surgery, I had this and that and the other, and then you might think, well, it's justifiable to do a hysterosalpingogram to determine whether this woman has fallopian tubes that are patent. Same thing as she says, I've had several episodes of chlamydia, I've had several STDs, and that might justify the workup. The other thing you have to remember, and there's no significant association between first trimester terminations, that is a medical abortion or a induced abortion in the first trimester, and infertility. So they'll come in and say, well, I had 3 terminations. Does that make me infertile? Well, no, not unless it's been associated with an infection or some other thing that might jeopardize the fallopian tubes or the cervix. Now, late abortions, then you have to worry about how was the cervix dilated, how were things done, and you might be thinking about some sort of a cervical incompetence. But anyway, that's getting a little bit off of the subject. But again, what do you do to conceive? Well, you have intercourse, and 80% of couples will have no problem doing it. It's a lot easier to get pregnant than you think. I have lots of teenagers in my practice that prove that. And that's pretty much all I can think of at this point. I think I answered your 4 questions. Now, the one about regular periods, again, like I said, 90% chance that if you have regular periods, you're ovulating. So if the woman has been diagnosed with infertility and excuse me, and she has regular periods, then you have to think about, is there something interfering with her fertility in the uterus? Fibroid sometimes acts as a deterrent to implantation, so she cannot get pregnant. Is there something blocking? Is there a fibroid blocking the fallopian tube? Are there blockage of the fallopian tubes because of infection or PID or something of that sort? But ovulation you can determine by either an ovulation predictor kit. The traditional way of doing it is by doing basal temperature checks or charts, and that is a little difficult because the way you do that properly is to have a thermometer by your bedside, and before you do anything else in the morning, you have to take your temperature and record it. And the increase at ovulation is a very slight increase in the temperature. But some women are very good at doing it, and they have conceived doing that, just doing body temperature charts or basal charts. The other way is you can measure the LH surge, at the time of the mid-cycle to see whether she's ovulating or not. But if you have somebody that is menstruating on a regular basis and is not able to conceive, you've got to think about blockage of some sort or interference of some sort. Some women have a discrepancy between the cervical mucus and ovulation. In other words, when you ovulate, the cervical mucus lightens up or becomes more watery, and that allows the sperm to penetrate. Some women have a difficulty with that. It used to be that if you gave them, and I do this sometimes if I have a question, is you tell them to start taking some a mucolytic cough suppressor, and that will affect every mucus in the body, so it also affects the cervical mucus, so that makes it more amenable for the sperm to penetrate. So that's pretty much it on that 4th question. Yeah, I think so. The easiest way of predicting ovulation is if you have somebody with regular menstrual periods, is to just do the calendar thing. Subtract 14 from whenever she starts her cycle, and that will give you ovulation in the mid-cycle. Any other questions? Am I still here?